Yeah.
Yeah.
Okay, so I will go ahead and just interrupt me if it's not working. It's my first experience presenting via Teams. So good afternoon, everyone. My name's Jane Reevy, and I'm one of the ST1 trainees currently working in Reading. And this afternoon, I'm going to talk about menstrual disorders. I'm sorry, I'm hesitating because the screen's not changing. There we go. Great. So a little bit of an outline of what I'm going to cover. Firstly, thinking a little bit about the physiology of menstruation and what normal bleeding is. Talk about the terminology to describe abnormal uterine bleeding, and then assessment and management of menstrual disorders. So I'll mainly focus on heavy menstrual bleeding, but also cover a bit about amenorrhea and infrequent menstrual bleeding. So firstly, this diagram, very familiar to you all, I'm sure, of the normal menstrual cycle. And this is a textbook 28-day menstrual cycle. And we know that during the secretory phase, progesterone is the dominant hormone. And then in a non-conception cycle, the corpus luteum regresses, and it's this dramatic decline in progesterone that triggers inflammation within the endometrium and shedding of the endometrium during a period. And human females are actually one of the very few species that menstruate. This is a little bit of trivia. Other species that menstruate include old world primates, the elephant shrew, the fruit bat, and more recently discovered the spiny mouse. And in developed countries today, women can expect to menstruate more than 400 times before menopause. And this is in contrast to women in the developing world or in previous centuries, where they had multiple pregnancies, having large families, had then prolonged lactational amenorrhea, went through puberty later, and also had a much shorter lifespan. And so then women may only have had about 40 menstrual bleeds during their lifetime. So whenever you consider that, you can see that actually menstrual abnormalities are much more common nowadays in modern society. So what is normal menstrual bleeding? And this table comes from a paper published by FIGO that classified the normal parameters of bleeding. And this is based on population data, and values between 5th and 95th percentile were classified as normal. So the normal frequency of periods, so cycle length, is between 24 to 38 days. And even within a normal regular cycle, it is normal to have a little bit of irregularity. And actually, over about 12 months, there can be variation in cycle length of anything between 2 and 20 days. The normal duration of a period is between 4.5 to 8 days, and the normal monthly blood loss is between 5 to 80 mils. So thinking now a little bit about the terminology. So in this same paper published by FIGO in 2011, they also discussed terminology that should be used, and there was a meeting to try to come to a consensus on terminology. And they advised that sort of older terminology such as menorrhagia and dysfunctional uterine bleeding should be abandoned, as often these words can be confusing. And dysfunctional uterine bleeding as well, you know, what is that? Is it a symptom? Is it a diagnosis? So what they have advised, and what I would sort of recommend as well, sort of early on in your training, is that you use the umbrella term abnormal uterine bleeding, which basically means any departure from normal menstruation or from a normal cycle pattern. And then use the term heavy menstrual bleeding rather than menorrhagia. Heavy and prolonged menstrual bleeding, irregular menstrual bleeding. They also advise that the term oligomenorrhea should be abandoned, though it's still used quite a bit, but instead of that, use infrequent menstrual bleeding. They advise amenorrhea can still be used because it's quite clear what that means, along with intermenstrual bleeding and postmenopausal bleeding. So what is heavy menstrual bleeding? And this is the definition from the NICE guidelines. It's a clinical definition, so it's excessive menstrual blood loss which interferes with the woman's physical, emotional, social and material quality of life. And it can occur alone or in combination with other symptoms. So if a woman feels that her periods are heavy and is troubled by this, then that is heavy menstrual bleeding, and we as doctors can give advice and help with this. However, an objective definition, as I mentioned, is a menstrual blood loss greater than 80 mils per cycle. And this is only really ever measured now in a research context. And you can see this is just sort of to illustrate, in some research studies, some women can have really heavy periods and lose up to about 450 mils. So clearly this is very debilitating. And heavy menstrual bleeding affects about 1 in 3 women. So it's a very common cause for referral to the gynecology clinic as well. And it has significant socioeconomic impact as well, especially now in today's society, as we said, women having more periods and also working more in the workplace as well. So cost of time off work, time off school for younger girls too. So I'm going to introduce this early on, again from FIGO, and this is a way of classifying causes of abnormal uterine bleeding. PAM coin, and it's very helpful too, because whenever you're taking a history as well, if you're thinking about PAM coin, it sort of makes sure that you've covered all symptoms to be asking about. So thinking about this, looking at causes of abnormal uterine bleeding, in which heavy menstrual bleeding is an entity under this umbrella term. So PAM is the structural entities, and these are entities that are picked up via imaging or histopathology. So polyps, that cause intermenstrual bleeding, adenomyosis, leiomyoma, or malignancy. And then COIN is the non-structural entities, so coagulopathy, ovulatory dysfunction, endometrial dysfunction, and that's a diagnosis of exclusion, iatrogenic, and not otherwise classified, and that covers sort of the rarer entities like arteriovenous malformation. So if you're seeing a woman in clinic who has been referred because of heavy periods, in terms of history, you want to know how long this has been on for, how many days she bleeds for, passing clots, does she have to use double protection, how is this impacting on her quality of life? And always, again, thinking about PAM coin, you just want to make sure as well, is there any postcoital bleeding, intermenstrual bleeding, pelvic pain or pressure that might make you think about fibroids, and also to cover this mirror history as well. On examination, there may be a pelvic mass. You want to do a speculum just to check for local causes, and this is especially if there's postcoital bleeding or intermenstrual bleeding. And then a bimanual examination to elicit if there's any masses or tenderness. In terms of laboratory tests, all women, I think, especially if they've been referred to hospital with heavy periods, should have a full blood count taken just to make sure they're not anemic. But you only need to test for coagulation disorders such as von Willebrand's disease if a woman has had heavy menstrual bleeding since menarche, and also personal or family history suggestive of coagulation disorders. So you'd want to sort of ask about easy bruising, nosebleeds, bleeding after surgery, or tooth extraction, and those would all be factors that make you think, oh, maybe we should be doing a coagulation screen as well. And actually, 13% of women who present with heavy menstrual bleeding will have von Willebrand's disease. Thyroid function tests only really need to be checked if a woman has symptoms of thyroid disease, because hypothyroidism is associated with heavy menstrual bleeding as well. So in terms of investigations, all women, especially if they're being referred to hospital, should have an ultrasound scan to see is there the appearance suggestive of adenomyosis, to see if there are fibroids present. Endometrial biopsy is up for a little bit of debate in a number of areas. So an endometrial biopsy would need to be taken if you're concerned that the woman may have endometrial hyperplasia or malignancy. So it would be required if there are risk factors for this. If a woman has persistent intermenstrual bleeding, want to think about that. If women are 45 and over with treatment failure or ineffective treatment, they should have a biopsy. Or women who are under 45 and who have risk factors such as obesity, which is a risk factor for endometrial hyperplasia. And then the next debate will be, should this be done by Papel biopsy or outpatient hysteroscopy? And the nice guidance in 2018 was sort of advising that all women should have an outpatient hysteroscopy, and it seemed that maybe there wasn't going to be such a role for a papal biopsy anymore. And just to pause as well, just to make sure, I'm sure you all know what a papal biopsy is, but that's sort of the little picture on the screen there as well. It's a little fine straw that goes up through the cervix, pull it back, and you can take a little biopsy that way. It can be a bit uncomfortable, but it's normally quite well tolerated, and it means you can get a biopsy whenever you see the woman that day in the clinic. However, if you're really concerned about potential endometrial hyperplasia or malignancy, then at outpatient hysteroscopy, you're actually looking at the endometrial lining and you're taking your biopsy, targeted biopsy from the areas that may be concerning. So in terms of advice on this, I think you would be guided by the case, you'd be guided by the consultant. There's no real clear-cut guidance yet as to whether a woman should definitely be having an outpatient hysteroscopy or a papal biopsy. And that may come into place in the next few years. But especially at the moment, in the current situation, with outpatient hysteroscopy maybe being more difficult with appointment timings and trying to prioritise really high-risk patients, maybe there still is a role for papal biopsy. So I haven't really answered that question, but I'm sort of saying it is an issue and it's an area of debate. MRI scans would be done really for further assessment of fibroids. If a large fibroid is picked up an ultrasound scan, an MRI is much better at saying exactly where it is, and also help to planning treatment if women want to think about uterine artery embolization, which I will come on to shortly. So in terms of management of heavy menstrual bleeding, as with everything, conservative, medical and surgical. And in conservative management, I think really a good explanation of the possible reasons for heavy menstrual bleeding or the possible causes that have been excluded. Information provision to aid the woman's decision making. If the woman is anemic, she'd have iron tablets. And weight loss, because actually if a woman is overweight or obese, there is now some evidence that raised BMI is associated with heavy menstrual bleeding. So it would be advice and support with that if relevant. Medical management, then divided into non-hormonal or hormonal, and surgical management. So in terms of non-hormonal treatments, it's really tranexamic acid and mefenamic acid. So tranexamic acid is an antifibrinolytic, so really should be used with caution if someone's had a previous venous thromboembolism. Suitable for use if a woman is trying to conceive. So some women may be coming to clinic with heavy periods but are wanting to try to conceive as well, so they don't want to take any hormonal medication, and then they could consider this. And it can be very effective, and it can result in approximately 50% reduction in blood loss. Mefenamic acid can be added into that. It's an NSAID, so it limits inflammatory mediators, and it's really good for pain. So if it's not just the quantity of blood loss but also pain, tranexamic acid and mefenamic acid can be taken together. Very little side effects. It would just be GI upset, if anything. And a woman can try that for 3 months. If they haven't had any improvement after 3 months, it's not going to work for them and they should stop it. However, if it is helpful, then it can be used long term. And it also can be added in, if a woman is on hormones as well, that can be added in as well to try to get better control of bleeding. In terms of hormonal management, I put at the top the Mirena coil, and nice to have this or at the top of their treatments as well, because it can be very cost effective as well. Because if it's effective, it can stay in for 5 years, and it can decrease blood loss by up to 96% after 1 year of use. The problem with it is that often very commonly actually, in the first 3 to 6 months, women can have irregular bleeding. And in about 20% of women, this can persist. But if a woman's going to consider a coil, it's really important to talk to them about that and say, if you really can, to stick with it for 6 months just to give it the best chance of being effective for you. And women who are troubled with hormonal side effects, with the Mirena, progestogenic side effects are much more limited as it's really sort of acting locally on the endometrium. The combined oral contraceptive pill is another really good hormonal option that can reduce blood loss by 50%. However, there are quite a few women who can't take the combined pill because it's contraindicated if there's a BMI over 35. in women who smoke and are over 35, and if there's a personal strong history of a blood clot, migraine with aura, high blood pressure, or breast cancer. So actually there are quite a few women who can't take the pill. The progesterone-only pill is not actually that great for the treatment of heavy menstrual bleeding. It's often associated with irregular, non-predictable blood loss, but it's really just an option that's there to try if no other options are suitable. Because actually, in about 20% of women, they can have no periods at all on the progesterone pill. So it is worth trying if nothing else is an option. The depot is very good, and about 50% of women will be amenorrheic on it. So its mechanism of action with a high dose of progesterone, it inhibits FSH, and this inhibits follicle development, preventing ovulation. But also then will reduce estradiol. So women who are on the depot may have a transient reduction in bone mineral density, but this normally restores with stopping it further down the line. The problem with the depot is it can be associated with side effects of weight gain and acne. So many women aren't able to tolerate it because of that. Oral progestogens, so norethisterone or Provera, they're really good for managing acute episodes of bleeding short term. And this is because actually they're associated with sort of a high incidence of progestogenic side effects. So they can be really effective at reducing blood loss by over 80%, but the side effects really sort of put many women off trying them longer term. So normally if a woman comes in with very heavy bleeding to hospital, you can put it on a sort of 5-day course of Provera or norethisterone. GnRH analogues are also very effective at stopping periods with an amenorrheic rate of 90%, but the problem is menopausal side effects, and women often then need to be on add-back HRT for bone protection. GnRH analogues are probably best for women who are, say, sort of in the perimenopause, in the late 40s, and maybe are starting to get maybe some menopausal symptoms anyway. Because then it's very effective, and actually some of these women then often don't want to come off it. It's so good, but you don't want women to be on it too long because you need to be thinking about their bones. It's also very useful for women with larger fibroids, just to try to shrink the fibroids a bit, normally prior to considering surgery. Which brings me on to surgical management of heavy menstrual bleeding. So one option to consider is endometrial ablation. And I was going to say, actually, a lot of you may have seen this, but actually you may not have, because we haven't really been doing much operating in the past 6 months. So what this is, picture on the bottom left of the screen, most commonly used is Novocure radiofrequency ablation. You can see there's a little gold wand. Goes up through the cervix into the uterus, and the radiofrequency ablation really sort of burns the endometrium. So the second image is a pre, and the final image is a post ablation, and that's a very effective ablation there on the far right. And again, this can be very successful in reducing bleeding at 1 year, up to about 98% of women. However, sometimes not all the endometrium is ablated. Sometimes it can grow back again. So actually, re-intervention rate in 5 years is about 8%. But overall, 30 to 75% of women will have no periods after having an ablation. In some units, I've worked in a unit previously where if a woman wanted to consider having an ablation, she had to have a really good form of contraception. So either have been sterilised or her husband have a vasectomy. And I think it's because in that unit one time a woman had an ablation and then she became pregnant, and it was not good outcome. So it is not contraceptive, and women need to be counselled about that. Also, as you can imagine, even just from seeing these pictures, it's not going to be suitable for all women. So say a woman has heavy menstrual bleeding because of a fibroid. If the fibroid is less than 3 centimetres and it's not distorting the cavity, then endometrial ablation would be possible. But if it's bigger than that, or if there's a distortion in the cavity, then you're not going to be able to ablate all of the endometrium. And if it's a larger uterus, bigger than 10-week size, then again, not all the endometrium is going to be ablated. So it's not going to be suitable for everyone. Other surgical options for heavy menstrual bleeding. So, and to put a diagram just on the side of fibroids, because these are options really to consider if women have fibroids, depending on their location. Myomectomy, either open or laparoscopic, depending on the size and location of the fibroids, or TCRF, so transcervical resection of the fibroid, if it's a submucosal fibroid in the cavity. Another option, depending on size and location of the fibroids, is uterine artery embolization, which is done by the interventional radiologists. And this actually can have a similar efficacy to myomectomy. 80% of women have an improvement in 1 year, much shorter hospital stay. It can, however, be associated with early ovarian failure, because some of the uterine artery vessels that are embolized, the blood supply to the ovary, there's ovarian and uterine anastomosis, so sometimes the blood supply to the ovary is affected as well. If early ovarian failure does happen, it's actually more common in older women over 45. And again, not all fibroids are going to be suitable for embolization. As you can imagine, even looking at this diagram here as well, the pedunculated fibroid on a very narrow stalk is not going to be suitable, because it'll be hard to embolize those vessels. And also, if there's a large fibroid that's actually protruding into the uterine cavity, that's not going to be suitable either, because even if it's embolized, then and there's ischemia and necrosis of the fibroid, then it can get stuck in the cavity too. And finally, final surgical management option is hysterectomy, which is normally after women have tried other options, other medical management options with much lower risk, and of course, once their family is complete. Moving on now, just to cover as well amenorrhea and infrequent menstrual bleeding, and then if we've got time, I'll just talk through a few cases and go back to the PAM coin that I discussed. So amenorrhea also comes under this umbrella term of abnormal uterine bleeding. It's an absence of menstruation, and either primary or secondary. So primary amenorrhea is failure of menstruation by the age of 16 years in the presence of normal secondary sexual characteristics, or 14 years in the absence of other evidence of puberty. And secondary amenorrhea is defined as absent periods for at least 6 months in a woman who's previously had regular periods. And it's either going to be a problem with the hypothalamic pituitary ovarian axis or an anatomical problem. So we'll keep referring back to this diagram just to think. So thinking first of primary amenorrhea, and Professor Becker may have covered some of this in his previous talk. I didn't hear all of it, but he may well have covered a little bit of overlap. Thinking first of the hypothalamic pituitary ovarian axis. So causes of an aberration in endocrine regulation, it may be a chronic illness. So a childhood chronic illness may compromise hypothalamic function. Childhood cancer, if they've had cranial radiotherapy, again, is going to compromise it. Other endocrine causes such as prolactinoma, thyroid disorder, adrenal disorders are all going to impact on this axis. Kalman syndrome is very rare, 1 in 50,000, and that's where there's a congenital absence of the GnRH neurons. So the pulsatile release of GnRH is never happening. Turner syndrome as well may present with primary amenorrhea too. And then thinking of congenital abnormalities of the genital tract, Rokitansky syndrome, which Professor Becker talked to you about, may present with primary amenorrhea, and also perfect hymen or transverse vaginal septum. And another very rare disorder, androgen insensitivity syndrome, affecting 1 in 60,000. So they are genetically male, so the gonads are testes, so they don't have a uterus, but they are resistant to androgens, so have female physical traits. In terms of secondary amenorrhea, causes of secondary amenorrhea really be guided towards them depending on the hormonal profile. So all women with secondary amenorrhea should have an FSH, an LH, and estradiol scent. So in terms of ovarian causes, we'd expect to see a very high or higher FSH, LH, because it's really trying to work on the ovaries to get them to function. PCOS is the most common cause of secondary amenorrhea. And actually, in a lot of women with PCOS, I'm going to come on to that shortly, the FSH and LH will actually be in the normal range, but it's the ratio that's a little bit altered. Premature ovarian insufficiency affects about 1% of women under 40 years. And in these women, FSH level will definitely be raised. Thinking about hypothalamic or pituitary causes, and in these women, you'd expect FSH and LH to be low. So what can cause this? So stress, women, if they're doing a lot of running, a lot of exercise, have a low BMI, that can be a cause of secondary amenorrhea. Prolactinomas, so high levels of prolactin inhibit GnRH secretion. Thyroid or adrenal disorders as well will impact on this. Sheehan syndrome is now much rarer. I don't know if any of you have heard of it before. This is whenever a woman has a baby, after baby's born, has a significant PPH or major obstetric hemorrhage, and has hypoperfusion to the pituitary gland, and then may make hopefully makes good recovery, but actually then her periods never start back again. And I think it was previously more common whenever women were having their babies at home more, and having major bleeding at home that wasn't managed so quickly. Craniopharyngioma is a very rare tumour of the pituitary gland. And then thinking of abnormalities of the outflow tract or uterus that can cause secondary amenorrhea. Asherman syndrome is whenever a lot of scarring develops within the endometrium. It again is rare, but any procedures such as surgical management of miscarriage or infection can cause scarring within the endometrium. It would be unusual, I guess, for it to be so extreme that it presents with secondary amenorrhea, but it is one cause to think about. And cervical stenosis, if a woman has had a LEPS procedure, there may subsequently be severe scarring in the cervix, so the menstrual blood is not able to pass. Seeing a woman in clinic who presents with amenorrhea, and really it's going to be most commonly secondary amenorrhea, because primary amenorrhea will be being seen in a pediatric clinic or adolescent clinic, so we're not going to be seeing it normally in gynae clinic. But you need to sort of ask, what was their periods, what they used to be like? Has anything changed? Have they lost a lot of weight recently, under more stress, exercising more? Do they have any menopausal symptoms, if you're thinking about premature ovarian insufficiency? Thinking about Asherman's, have they had any uterine surgery? Is there a family history of premature ovarian insufficiency? And then a systematic inquiry if you're thinking about other causes, such as prolactinoma, such as headache or galactorrhea. Examination, BMI is important, pelvic examination. If it's primary amenorrhea, you're going to be thinking about secondary sexual characteristics. But as I said, you wouldn't be seeing women like that, the girls like that, in the normal outpatient clinic. In terms of investigations, always good to do a pregnancy test for secondary amenorrhea. A hormonal profile, as I mentioned, ultrasound scan, and then other investigations are really going to be guided by what you suspect the cause may be. So if you're thinking about prolactinomas, then it's thinking about CT, MRI, head, karyotype for Turner's, hysteroscopy, if you're thinking that they may have Asherman syndrome, so if they've had previous uterine surgery. And management, again, is going to be specific to the cause. So if a woman does have a lower BMI, then it would be sort of advice and diet and trying to increase her weight a bit, just so it's at the level that the hypothalamic pituitary ovarian axis can kickstart again. Girls and women who've been diagnosed with Kalman syndrome will need to be on HRT and have pulsatile GnRH therapy. This is very subspecialised. Pituitary causes hyperprolactinemia would be treated with a dopamine agonist, and normally then once prolactin comes back down in the normal range, their cycle will start back up again. Ovarian causes, premature ovarian insufficiency, women will need to be on HRT. And Asherman's, if it's diagnosed at hysteroscopy, can be treated by a TCM lysis. Now, just to talk, because again, I've got an eye on the time here. I'm covering gynae as well, so I need to get up to the word. Infrequent menstrual bleeding, or as it can also be referred to, oligomenorrhea. Though, as I said, that's sort of the older terminology. The most common cause of infrequent menstrual bleeding is polycystic ovarian syndrome, and this is one of the most common endocrine disorders in women of reproductive age. The prevalence, I mean, it varies between 2% and 26% because of differences in the criteria employed, but it is relatively common. It should be diagnosed based on the Rotterdam criteria, because sometimes women have had a scan and it shows that the ovaries have, possible polycystic appearance, and then they're very concerned about this, but actually they're having regular periods, they've got no symptoms of hirsutism. So you say, no, you have polycystic ovaries on scan, but you do not have polycystic ovarian syndrome. Because to have the syndrome, you need to have 2 out of the 3 diagnostic criteria. So the scan appearance of ovaries, you see in that figure, infrequent periods, or amenorrhea, and clinical or biochemical signs of hyperandrogenism. The cause of PCOS, there's lots of research going into this. The actual cause is unknown, but it's likely to be a very complex, multigenic disorder with both epigenetic and environmental influences. It is associated with family history, so if a woman's mother has had PCOS, they have a higher chance of having it as well. Weight gain and thinking about obesity, there's a lot of debate as to whether obesity is the cause or consequence of PCOS, and as well, not all women with polycystic ovarian syndrome are overweight. There's a lot of women with a normal BMI or a low BMI as well. But we do know, in terms of the pathogenesis of it, it's characterized by signs and symptoms of excess androgen synthesis by the ovaries, and this disrupts the hypothalamic pituitary ovarian function. And the phenotype of PCOS is very variable. Some women have very irregular periods or no periods at all, hirsutism to different degrees, acne, have male pattern baldness, struggle with weight loss, and insulin resistance is actually present in 65 to 80% of women with PCOS, independent of obesity. So this sort of comes back to it being a multi-genetic disorder and lots of genes involved and overlapping with metabolic syndrome as well. In terms of investigation, obviously to make the diagnosis, women would have an ultrasound scan, and blood tests can be done, but they don't need to be done to make the diagnosis. A lot of the time, women have been referred to clinic, and their GP have actually have taken the bloods, so you are presented with bloods. In PCOS, there can be an increased LH to FSH ratio. Sex hormone binding globulin is often reduced, and this is the protein that binds testosterone. So testosterone that isn't binded is free and active testosterone. So in the assays, often the total testosterone is normal, but the free testosterone is elevated, and that's because sex hormone binding globulin is reduced. So it's the free androgens that would be measured and raised in PCOS. In terms of the management, if a woman is overweight, weight reduction can improve endocrine profile and ovulation. Longer term, women who are amenorrheic or having very infrequent periods are at a higher risk of endometrial hyperplasia. So that needs to be considered, and they need to be on some sort of treatment to protect the endometrium. That could be the Mirena coil, or it could be inducing a bleed about 4 times a year by taking Provera, a short course of Provera to induce a bleed, or taking the combined pill or the progesterone-only pill, anything to protect the endometrium. Women who are very troubled by hirsutism can use topical agents to help with that. But also what can be very helpful is Dianet, and that's the combined pill, but it's a non-androgenic progesterone cyclosporine acetate, and that can be helpful if they can take the combined pill. When you're seeing women in the clinic, and often women are referred to clinic because their GP has made the referral, and it's really just for it's really just for a chat and a talk through them about what the diagnosis is and thinking longer term, because a lot of women then be worried about their fertility, and it may not be something that they're thinking about at the moment, but it is something longer term. And we can advise that actually, if they may well be ovulating spontaneously, but if they're not ovulating, there are lots of treatments that can be considered. It doesn't need to be IVF. They could have ovulation induction with letrozole or protein citrate. Longer term as well, women with PCOS have a higher risk of developing problems with raised blood pressure, a higher risk of having diabetes. So that's something really to be checking in with their GP over the years. The RCG have a very good patient information leaflet on PCOS. But if I'm seeing a woman in clinic and they're not too sure about the diagnosis, I print off and give to them as well, because it's give a lot of reassurance and answer questions as well. I have a couple of case studies that I can go through quickly, just because it sort of highlights the palm coin tool, which I really think is very useful, and it's a very useful way of classifying causes of abnormal uterine bleeding, of which heavy menstrual bleeding is an entity. So I'll talk through this first one. Obviously, if we were more face to face, we could go into groups and sort of have a bit more interaction. But I'll talk through and then we'll see. So first case study to think about: 32-year-old woman, para 1, having cyclical heavy menstrual bleeding, normal BMI, previously been sterilised because she's had side effects from her hormonal medication. She actually had a coagulopathy screen, which was normal. Her hemoglobin came back at 98. She had a scan that showed a normal uterus. So thinking, do you have the answers ready on the next slide? Thinking of the causes of her abnormal uterine bleeding. It's a normal scan, so no polyp, no adenomyosis, no fibroids. You don't have to think really about malignancy with her. There are no risk factors for it. She's having regular bleeding. She's had a normal coagulopathy screen that's not ovulatory. She's having regular periods. No other medications, not otherwise classified. So the most common cause for her is going to be endometrial, so AUBE. And this is heavy menstrual bleeding that occurs in women with normal ovulatory cycles. They have a normal uterus. There's no coagulopathy, and this is thought to be secondary to endometrial causes. And there's a lot of research going on into this, just to work out, what is it in the endometrium that is causing the repair following a period to be delayed. And is there impaired local tissue, hemostasis, impaired repair factors? And actually, I think a lot of women, there's no cause found for their heavy menstrual bleedings. If you're seeing them in the clinic, you just need to be reassuring that actually we've ruled out all causes, and at the moment we just don't know exactly what's causing this, and it's an area of ongoing research. But treatment options, thinking of treatment options for her. She's anemic, so some iron tablets. Tranexamic acid may be helpful because she wants to avoid hormones, or the Mirena coil because it's less associated with hormonal side effects. Or she would be suitable as well for endometrial ablation, if that's something she wished to consider. I might just talk through these case studies quickly, if that's okay, because it's maybe easier in terms of time. Case study 2, 28-year-old nulliparous, cyclical bleeding since menarche. Previously used the combined pill but wasn't able to tolerate it. Obviously wants to preserve her fertility, but she also has a history of easy bruising. So if you were seeing her in clinic and you're thinking about palm coin and you're thinking about coagulopathy, those are the questions to ask. So she's someone that should have a coagulopathy screen done. She also had a scan done that showed these large fibroids here. So in terms of classifying causes of her abnormal uterine bleeding, would be AUB-L, fibroids, and possibly C, once the coagulopathy screen is sent. And options for her, I mean, for all women, conservative management, we don't have to do anything, but most women, if they're seeing you in clinic, they do want some sort of treatment. She wants to avoid hormones. Tranexamic acid could be helpful, but they were quite large fibroids, so it may not well be enough. And then it's thinking about options that would be conserving her fertility, uterine artery embolization, or laparoscopic myomectomy. Another case, 39-year-old, para 1, 12-month history of irregular heavy bleeding. Also has raised BMI of 34. It's anemic with an HB of 80. Because of her irregular heavy bleeding and higher BMI, she had a biopsy taken showing simple endometrial hyperplasia. She also reported increased urinary frequency and her family was complete. And this was her scan. So lots of fibroids, big multifibroid uterus. And in terms of causes for her AUB, it would be L for fibroids and M for endometrial hyperplasia. And in terms of treatment options for her, obviously she's anemic, needs some iron tablets. GnRH analogues may well help to shrink the fibroids. Weight loss as well needs to be considered. But ultimately, in her case, there would be a discussion, because if she has endometrial hyperplasia, the treatment for that would be with progesterones. But actually a longer term option, you know, for her as well, if she's having significant heavy menstrual bleeding with large fibroids, it may be that hysterectomy might well be the best option in her case. And final case study to run through as well, case study 4, 30-year-old, no children, regular heavy menstrual bleeding, gradually getting worse, severe dysmenorrhea impacting on her work as well, currently just using condoms for contraception. She had an ultrasound scan. This scan, a little bit hard to see, but it's actually sort of showing quite a globular appearance of the uterus that would be in keeping with adenomyosis. And that's whenever the endometrium is within the myometrium. And women with adenomyosis typically have heavy periods and very painful periods. So her classification would be AUB-A. Treatment options, tranexamic acid and mefenamic acid certainly could be tried, but what probably would be most effective for adenomyosis would be to try the Mirena coil, if she wished to consider that. So I just wanted to do this case studies just to give sort of a run through about using PAM coin to help with your history taking, guide your planning of investigations, and also just so it's quite clear in your head when you're seeing a woman, what do we think the cause of her heavy bleeding is? So to summarise what we've discussed and gone through and the learning, we've focused on the terminology and moving away from the older terminology such as menorrhagia and dysfunctional uterine bleeding, and thinking about AUB and heavy menstrual bleeding. So that's a real important take-home message. We've covered normal bleeding parameters. We've thought about investigations and management of heavy menstrual bleeding, and also thinking about amenorrhea and PCOS, and also using the PAM coin, the FIGO classification, to diagnose cause of AUB. So references as well. So thank you very much. I'm just going to exit this screen. If anyone has any questions.